Can we start?
Yes, now I'm live.
So good morning, good evening, and good night from everyone across the globe that's joining us for this edition of the EIOC, and happy Thanksgiving to everyone who's celebrating it today.
Thank you.
My name is Shaheenah Dawood. I'm a consultant medical oncologist coming to you all the way from the actually nice weather here in Dubai now. So if anybody would like to hop over, we have some really nice weather. I know, Rob, you enjoyed yourself when you were here a couple of weeks ago.
Absolutely.
Today we've got an amazing lineup. We've got Rob Coleman coming to us all the way from Texas, and Isabelle that's coming to us all the way from France. And what we're going to do today is but the two of them are going to give us updates on what's worked and what hasn't worked in the realm of gynecological malignancies in 2025. Rob, I'm going to let you introduce yourself.
Okay, thank you so much. Yeah, so Rob Coleman, I'm a gynecologic oncologist in Austin, Texas, as you mentioned. I serve as the vice president for GOG Foundation and the chief medical officer for Vanium Group. So great to be with you. Thanks for the invitation.
Isabelle?
Hello everyone, I'm Isabelle Coquard, medical oncologist working in the Comprehensive Cancer Center in Lyon, France, and I'm very happy and honored to be with you today.
Thank you. So without further ado, Rob, I believe you've got the first talk. You're going to be talking about practice-changing updates from SGO, ESGO, ESMO, AACR on ovarian cancer before Isabelle takes it off from ASCO and ESMO. So you've got a lot to cover, Rob. I hope you can do it in that short period of time.
Yeah, thanks. So for people that are watching, so as you mentioned, it's Thanksgiving, so I know that there's a lot of traffic going in and out of my house, so I actually pre-recorded this. And one of the values of pre-recording your talk is that you can then make it fit into the time slot. So unlike Isabelle, I'm challenging you, girl. I'm going to get mine into the 15 minutes. So go ahead and roll tape. Everyone, it's a great pleasure to be with you today. My name is Dr. Rob Coleman. I'm a GYN oncologist at Texas Oncology here in beautiful Austin, Texas. It's great to be with you and talking about top trials in gynecologic cancers, an update from the 2025 meetings. And I'll be focusing on ovarian cancer trials in the first line and in the platinum-sensitive space. And my good friend and colleague, Dr. Isabelle Coquard, will be talking about the platinum-resistant and recurrent space. These are my disclosures here. So with respect to the meetings, there's been a lot of information that's been processed. So it's very difficult to get this done in 15 minutes, but these are the general topics. I'm going to talk a little bit about surgery and then some of the adjuvant treatments that have entered into this space as part of the investigational landscape, and includes these one or more of the combinations of these class of agents, anti-angiogenesis agents, PARPs, PARP inhibition, ADC, and immunotherapy. So let me start with surgery. So the TRUST trial was recently reported, and this is a highly anticipated trial that was evaluating once again the role of neoadjuvant chemotherapy as a treatment approach to patients with advanced stage and high risk ovarian cancer. You can see the patients that were entered into this trial were stage 3B to C, 4A to B, and were considered resectable. Now, the nuance in this particular trial was that was based on several factors that came out of the previous studies, and I'll just highlight them here, where in the previous 4 trials that were done in the neoadjuvant setting, you can see there was quite a bit of variation with respect to operative time, which raised the question of surgical effort. We also can see that there's a fair amount of discrepancy in the amount of patients who achieved no gross residual, which can highlight either the patient selection process or, again, some of the surgical expertise and effort. And then with respect to outcomes, we saw quite a bit of variance in progression-free and overall survival, with PFS being between 12 and 16 months and overall survival being 23 to 49 months. So quite a bit of variability there. And under most of these circumstances, most clinicians have felt that these numbers were basically underrepresenting their experience. So one of the key features of the TRUST trial was to try to standardize for surgical effort. And I put this here on this table to outline some of the findings of this trial. As you can see that the median duration of surgery between the 2 arms was lower in the neoadjuvant chemotherapy, but both of these estimates are much above what we saw from the prior estimates in the previous trials that were done. And with respect to complete gross resection, you can see once again that these were more standardized between these two surgical modalities. But in the primary cytoreduction effort, you can see it was at the top end of the range that was seen in the previous multiple studies. And then with respect to progression-free survival, you can see that the overall outcome for both of the arms of the trial were around 20 to 22 months, again, showing that in this particular cohort of patients that this was, with this level of surgical skill, that there was improvement in that particular outcome. But and we also saw the same with overall survival, again, being at the topmost range of all of the previous studies combined. But the primary endpoint of this trial was overall survival. So although this was a superiority trial that was focused on to determine whether or not primary cytoreduction would be better than neoadjuvant chemotherapy, it missed on that endpoint. You can see the hazard ratio is 0.89 and p-value is not statistically significant. In fact, you can actually see that this is probably non-proportional hazards across the duration of exposure for overall survival. When we looked at the subgroups, you can see there was some variation within this specific subgroups as it relates to stage, ECOG status, and the proportion of patients getting complete gross resection. But in reality, none of these are significantly different than the overall trial result. And as such, we would conclude that there's basically a consistency in outcome, even in the subgroups. One of the things that was seen was that there was about a 50% higher rate of any complication, but both of these were relatively low, 12% for major complications in neoadjuvant chemotherapy surgery and 18% in the primary cytoreduction. And you can see that the major complications, such as relaparotomy, and other components of postoperative complications were relatively low overall, but potentially a little bit higher in the primary cytoreduction. So the conclusions the authors came to was that the primary endpoint of the study was not met. That's true. The TRUST trial they stated it was the first randomized trial to show a benefit in the median PFS in primary versus interval cytoreduction. You can see that they stated that the overall benefits were linked largely to the high complete resection rates, which reinforced the value of upfront surgery, and that there was that the high rate of cytoreduction associated with this particular trial was a result of quality control of surgery. So let me push back a little bit on this. I think the main thing to identify is that the primary endpoint of this trial was not met. So there was no difference in overall survival, and progression-free survival wasn't analyzed. So it wasn't an analytical benefit. So to say that it's the first trial to show a benefit is really an overstatement of that particular endpoint. Because of that, the third bullet is basically saying that it reinforces the value. Well, we didn't really test value. We showed that there was a higher rate of cytoreduction in both of the arms that we've seen in traditional methods, but it's really overstated to say that it has the radical surgery is actually is of better value. But there is, I 100% agree with this last bullet, was that surgical quality definitely needs to be assessed. And many programs have shown that when standards are raised amongst surgeons, there's less inter-surgeon heterogeneity, and so that we get more consistent results in the long run. Now, the next trial I want to focus on is ICON 8B. This was presented at ESMO. This was an update to an earlier report, but now providing evidence on overall survival. As you remember, this was a suboptimal cytoreduced and stage 4 patient population that was randomized between 3 arms. The arms A, B1, and B3 were basically looking at a single question, and that was dose-dense paclitaxel. Arm B2 was closed when it was shown that the weekly regimen was more efficacious. And so the rest of the trial went forward with this dose-dense idea. Now, the important part of this trial is that all the patients received bevacizumab and carboplatin in the same dose. And so the only variance here was the weekly paclitaxel. And as we saw in the initial report when this was presented 2 years ago, was that the PFS showed a benefit of 0.75, which was statistically significant. And this was counter to the hypothesis generating data from GOG 162, which suggested that there was a benefit to the dose-dense regimen only if bevacizumab was not given. So this was a formal phase 3 study that basically showed that that was actually not the case and that this was beneficial. With respect to the safety data, you can see that overall between the 3 arms of the trial was relatively consistent. There was between the dose dense and the Q3 week schedule. Overall, there might have been a little bit less anemia in the arm B1, which was the 3-week schedule. But overall, it looks like they were fairly well matched with respect to high-grade toxicity and any grade toxicity. The overall survival data were updated at the meeting, and you can see here once again that the overall survival was statistically better in the weekly dose-dense paclitaxel arm with a hazard ratio of 0.79, which was statistically significant. So this provided evidence of both PFS and an OS difference between the 2 arms, and they concluded appropriately that for these analytical endpoints, the dose-dense regimen was better for both of those endpoints and should be considered a standard of care option for high-risk stage 3 and 4 epithelial ovarian cancer. Now, there's one of the drawbacks from this particular trial is that we don't really have clean data on BRCA, and including half of the patients had BRCA, missing data for BRCA mutation status, and this may have been important, especially if it was imbalanced in the trial design. Now, the third component of the frontline study studies that have been done were the incorporation of immune checkpoint inhibitor therapy. And as you can see here, there have been multiple trials that have looked at either concomitant chemo IO followed by IO maintenance or pure IO maintenance strategies. And for the most part, these have been negative trials. The 3, as I've highlighted in red here, I put down as positives, questionably because they did meet some endpoints, but they've been very difficult to interpret because of the way the trials have been designed. So let me start with KeyLink. And of course, I have a conflict of interest here. I was an investigator on this trial and led for the GOG, this particular trial. But as you can see here, these were advanced stage patients who did not carry mutation of BRCA1 or 2 in their tumor or in the germline. And you can see that the control arm was carboplatin paclitaxel with the opportunity or the choice of using bevacizumab. If it was done, it was given during chemotherapy and during the maintenance phase. The arm 2 experimental arm was adding pembrolizumab followed by pembrolizumab maintenance, again in the presence or absence of bevacizumab. And third arm was the give paclitaxel carboplatin paclitaxel pembrolizumab plus or minus bevacizumab followed by olaparib, pembro, and bevacizumab optional. And as you can see, the primary analytical plan for this study was to look at this experimental arm number 3 versus control in the CPS greater than 10. And then in the ITT populations, this was formally hypothesis tested. And you can see at the first interim analysis that indeed it met its statistically significant endpoint with a hazard ratio of 0.66 and 0.71 for the ITT population. Then the next analytical step down was to look at the pembrolizumab arm versus the control arm. And you can see in the CPS greater than 10 that it did not meet statistical significance. So no further analysis was done with respect to the endpoints of the trial. So this is where the hypothesis testing stopped. Again, it is difficult to interpret because bevacizumab was optional, and we do not have a pure arm of just looking at the PARP inhibitor alone, which we know in the HRD test positive cohorts may have contributed something to this outcome. The first trial also was presented this year at ASCO. Initially started as a 3-arm trial, looking at paclitaxel carboplatin plus or minus bevacizumab as a control arm. If bev was given, it was given during chemo and maintenance, as I mentioned before with the other trials. The first experimental arm was to look at niraparib as a pure maintenance, and then niraparib plus dostarlimab to be given as a maintenance if it was given during the induction phase. So you can see already that because bevacizumab was optional, that there were some variants as to arm 2 and arm 3 with respect to outcomes, mainly because you can also appreciate that dostarlimab was given throughout both phases of the trial, both the induction phase and in the maintenance phase. So again, we don't have a clean example of what the immune checkpoint inhibitor is doing, and nor do we have a clean example of what bevacizumab is doing. However, in the overall intent to treat population of looking at the dostarlimab niraparib arm versus the niraparib alone maintenance arm, we saw a hazard ratio of 0.85, which was statistically significant in this very large trial of over 1,000 patients. When we looked at the the analysis in the PD-L1 positive, you can see that we don't see an effect in this, of course, non-analytical pathway, but we do not see a difference, a large difference emerging from this particular subgroup in an overall survival. Again, we see no difference. So the authors concluded that that the addition of dostarlimab to first-line platinum-based chemotherapy and maintenance niraparib was associated with statistically significant, though modest, endpoint improvement in PFS. It did not. It was not influenced by PD-L1 positivity. There were no difference in overall survival. The safety was stable. And again, if you put this along with the previously reported Duo-O trial, which is on the far right of this slide, you can see that all of these trials have produced at least one primary endpoint that was analytical, that was positive. The problem with all of these trials, though, is that they failed to appropriately identify what it is that's actually contributing to the benefit. And so while there are many hypotheses now that have been generated from the multitude of subgroups that have been analyzed, we don't have a clean example as to exactly what is driving the difference. And we'll have to see ultimately how these regimens are filed and have regulatory impact. Now, the other class that has been, we saw a lot of activity this year were the ADCs. As you know, there's many of these in development, over 190. Many of these are now associated with topo-1 isomerase inhibitors, although we also have tubulin poisons. At this year's ESMO, just for an example, in ovarian cancer, we had the reports of 3 different compounds that are targeting folate receptor alpha with topo-1 isomerase inhibitors, all of which showing around a 50% response rate in recurrent disease. In the we have another class or another cohort of drugs as a single targeting mechanism, looking at CDH6, HER2, and B7H4, again showing around a 50% response rate. And then we have the first look at a bispecific that's looking at EGFR HER3 with a topo-1 isomerase inhibitor, also producing around a 53% response rate. But in the small cohort of patients with platinum-sensitive disease, we saw a 77% response rate. And one of these that was had also another platinum-sensitive arm was the RDXD in this sub-study of the phase 1 group. And I have shown here this broken down by CDH6 expression, this particular agent. And you can see that in this platinum-sensitive group, it had a 72% response rate, which wasn't influenced much by prior progression on a PARP inhibitor as part of the cohort of patients that were included in the study. So again, it's small numbers, but again, highlights that these are of some value in the platinum-sensitive recurrent space. And indeed, there are many trials now that are ongoing and more planned that are in the public domain that are looking at the use of an ADC plus bevacizumab in the maintenance phase of platinum-sensitive patients. And there have also been some interest in looking at this with respect to patients who've progressed on PARP inhibitors. Not all of these are in the public domain yet, but I can tell you that there are 2 or so in progress. So with respect to take home, novel therapies are rapidly entering into our clinical paradigm in almost every treatment setting in the platinum for ovarian cancer patients. The ADCs are currently dominant, but we're always looking for what's next. And we really need to get patients onto these trials so that we can actually answer these questions. And with that, I'll close. Thank you so much for your attention.
Thank you, Rob. Excellent overview of all the amazing trials, and I'm pretty sure we're going to debate some of the data that you've presented. I'm definitely going to question you on Key-Link a little bit later on. But now let's shift over to Isabelle, and she'll talk to us about the trials that were presented with platinum-resistant ovarian cancer. So, Isabelle, take it away.
Thank you so much. Great talk, as usual, Rob. The challenge is very high for me. So, do you see my slide? Okay, so as mentioned by Rob, I will focus on the resistant ovarian cancer population, which is in general not the best, but sometimes it's interesting to remember that the innovation are coming from resistant ovarian cancer population. For our young colleague, I just want to remember that ovarian cancer is a very complex disease for several reasons, including the fact that it's not a single disease, but a constellation with a complete molecular profile different, which can explain also the different mechanisms of resistance to platinum. And the second point that we have to remember that unfortunately, also in the most frequent histology subgroup, high-grade serous ovarian cancer, 70% of our patients were diagnosed with an advanced stage, more than 70% with relapse soon after the initial diagnostic, explaining why until recently we have less than 50% of our patients alive at 5 years, and at the end all of our patients will become resistant to platinum. And in this setting, until recently, when BEV and PARP inhibitor were used more frequently in the first line setting, the only single agent chemotherapy, PLD weekly paclitaxel topotecan plus or less BEV, are our standard of care. Also, we consider that weekly paclitaxel remain our best option. And effectively, when you look at this table reporting the activity of weekly paclitaxel plus or less BEV in all the most recent clinical trial, you see that the response rate and the median PFS and overall survival remain the best in this setting compared to the use of PLD alone or topotecan alone. Considering the use of immunotherapy, Rob explained very well how, unfortunately, checkpoint inhibitor in ovarian cancer failed to demonstrate any benefit. And also, we have included more than 10,000 patients. There is no practice-changing result achieved, also in the resistant setting. There is now several conclusions considering that ovarian cancer is definitively a cold immunogenic tumor dominated by immunosuppressive pathway. The PD-L1 expression is low, in general less than 40% in the relapse setting, and they also consider that we need strong rationale for combination to better select the patient to include in clinical trial with Eioc. And this year arrived the B96 exploring the use of pembrolizumab in the resistant setting in combination with weekly paclitaxel plus or less BEV in a group of patients where we already have several negative trials. And we have seen during the ESMO conference the benefit in this final analysis of the PFS in the CPS positive population, but also in the ITT population. Also, you can see that the median benefit is short, 1 month or 2 months, but an interesting overall survival benefit, particularly in the CPS1 positive population at the time of the intermediate overall survival analysis, with a 4 months benefit in terms of median and another ratio of 0.76. Back to that, in considering the summary of the adverse event, we have to remember that we have 11% of patients with severe adverse events, particularly considering the discontinuation of treatment, close to 36%. Also, at the time of the presentation, we don't know if it is the pembrolizumab alone, the weekly paclitaxel, and the BEV. We see a certain number of patients to discontinue the treatment, and considering the immune-related adverse event, we see that colitis is much more frequent compared to the non-use of pembrolizumab. However, beyond colitis, we don't see a huge side effect using the triplet compared to the doublet. So first of all, how we can see a positive result in the land where we see only negative results until now. I would like to insist on the statistical design. We use a large international trial with a strong study design, high number of patients to be able to make a demonstration of positive effect when we increase the number of patients. Well-selected population for immunotherapy, considering few number lines of treatment before, and rich in the biomarker positive population. More than 70% of the patients were CPS positive. The use of the weekly paclitaxel, where we know we have several prospective but also preclinical data who confirm that the low dose of paclitaxel is able to modulate the activity and to increase the chance to have an immune response to PD-1 inhibitor, and the use of bevacizumab also makes some benefits, as we have seen the clinical demonstration in the Aurelia trial. But coming back to the weekly paclitaxel, I just want to remember you what we see in the ENGOT OV34 trial, where we are exploring the activity of atezolizumab plus bevacizumab plus weekly paclitaxel or PLD. The trial were negative for PFS and overall survival in the ITT population. However, when we look at the subgroup analysis looking to the use of weekly paclitaxel, we see a benefit in terms of PFS, but also in terms of overall survival, adding atezolizumab to weekly paclitaxel and BEV. Considering the role of BEV in the B96 is quite complex to measure because you remember that it is an optional treatment. However, if you look at the number of events in the group of patients receiving BEV compared to no BEV, we see clearly more progression and more deaths without BEV than with BEV. So looking at the Kaplan-Meier curve in these two subgroups of patients will be fundamental to understand if BEV is mandatory, yes or not, in a clinical trial where 70% of the patients receive BEV in this clinical trial. So how to put these results in the landscape? Also, we have seen new agents coming recently, relacorilant plus nab-paclitaxel, promising, mirvetuximab soravtansine already approved by FDA and EMA, and several EDC mentioned this year. Coming back to relacorilant, you have to remember that it is an agent targeting glucocorticoid receptor, and this compound, in addition with nab-paclitaxel compared to nab-paclitaxel, report positive results at the ASCO meeting this year in terms of progression-free survival. The hazard ratio is 0.7. That means 3 months, 30% decreased risk of progression, and a positive result in the intermediate overall survival analysis with an hazard ratio of 0.69, a maturity of 50%, and a median advantage of 4 months. The safety profile is quite good. We don't see a huge difference compared to nab-paclitaxel alone, except we have more hematological toxicity, but completely acceptable compared to what we know. They also report something which can be interesting in the future, looking to a new group of patients already mentioned by Rob before, is the patient who progressed during PARP, where we know with the PAOLA-1 data in terms of PFS and overall survival that this group of patients is less sensitive to platinum and could be interesting to explore alternative treatment in the future. And during the ESMO meeting, they report this subgroup analysis of the patient who progress during PARP, which is represent 50% of the patient in both arms of treatment, and they continue to report positive results in terms of PFS using this combination compared to nab-paclitaxel alone. Coming back to mirvetuximab soravtansine, which is now our standard of care for patients with FR alpha high population, we remember the results of the MIRASOL trial in terms of PFS overall survival benefit using this EDC compared to the standard of care. This year, we have an update analysis, the final analysis of the results, and Toon van Grop report the benefit in terms of response rate, and we continue to see a huge number of patients in partial or complete response using this EDC compared to standard of care, particularly the 5% of complete response. The duration of response, the median PFS2 continue to be significantly positive in favor of this drug compared to chemotherapy. Interestingly, the overall survival continued to be very well separated since the beginning. The hazard ratio now is 0.68. The median hazard value is quite to be more than 3.5 months in favor of this drug compared to standard of care. And considering the safety profile, we continue to see an advantage in favor of this monotherapy compared to chemotherapy, considering the safety profile, but also when we look at the overall survival, we see on the forest plot benefit whatever is the drug used in the control arm, specifically the weekly paclitaxel, which is something that we can debate later. The safety profile, I'll already inform about the safety, which is quite acceptable and in favor of the mirvetuximab. Also, we see a different safety profile, less hematological toxicity, but we know this ocular toxicity that now we learn to manage. How we can move in this landscape, we have to be very careful because the patient included in Mirasol, Rosella, and B96 are completely different, considering the prior line of treatment, the platinum-free interval, the use of BEV, which is mandatory in Rosella, frequently used in Mirasol, less than 50% in B96, the previous use of PARP before, the control arm, and the use of BEV in the clinical trial, which is open only in the B96. And coming back to that, there is also new treatment, and we have seen during ESMO new EDC coming in the landscape. We report the part 1 of the Regis Ovarian 01 study, which is a clinical trial exploring the raludotatug deruxtecan in platinum-resistant ovarian cancer. The part 1 is the Optimus program to identify the best dose to generate data for the phase 3. And we have report nice results using this drug in the platinum-resistant ovarian cancer with a response rate coming from 44% to 57% depending of the dose we are using, 4.8, 5.6, and 6.4. We see a huge benefit with tumor shrinkage for all the dose, and we also see an activity of this compound, whatever is the level of expression of CDH6 in this phase 1, part 1 of the Rejoice. Considering the safety profile, if we look carefully to the treatment-related adverse event, particularly for grade 3, but also the dose modification and the number of ILD, finally we consider that 5.6 milligram per kg is the most relevant dose to use for this drug and will be selected for the phase 3, considering that the most frequent side effects were nausea, anemia, asthenia, and neutropenia. But there is also other EDC, topo-1 payload, and we have the compound from AstraZeneca, this compound target FR alpha, and we see also a good activity using this compound with a response rate close to 56% using this drug. A median follow-up of 7.8 months report a nice data in terms of PFS-free evidence. We also see activity, whatever is the FR alpha expression using this drug with a topo-1 payload. There is also the Lilly compound who also report similar results in terms of activity, but also particularly for the patient who already received MIRV before, which is quite encouraging. And the safety profile of this drug is, as we anticipate, some nausea, fatigue, anemia, but globally very well tolerated. So looking to all this data, we consider now that the biomarker will be much more important in the future, but there is some challenge. And we have seen with the B96, looking to the ITT analysis, that the CPS positive biomarker for PD-L1 is possibly not the best one, and we are not able to make the difference between predictive and prognostic value of this biomarker. For FR alpha, we have seen a strong activity in the FR alpha high population, and so because we have mirvetuximab, one of the questions will be how we will mitigate the FR alpha high population and the PD-L1 CPS positive population. In lung and cervical cancer, it seems there is no correlation. In breast cancer, FR alpha over overexpression seems to be enriched in the triple negative breast cancer. For ovarian cancer, we don't know. We don't know how is the overlap between the two biomarkers. And for double positive population, it will be interesting to look also at what could be to consider mirvetuximab and pembrolizumab. And I just want to remember the data report by Ursula Matulonis using this combination. Also, the response rate was not really different to what we see with mirvetuximab alone. The duration of response seems very high in the FR-alpha high population, making some interest to explore in the future. So if we would like to conclude on the 2025 news for platinum-resistant ovarian cancer, we can say that paclitaxel bevacizumab remain our preferred option and control arm for platinum-resistant ovarian cancer. But we have to remember, at least in Europe, that many patients are not candidate or not able to access to bevacizumab in this group of patients, considering contraindication or any regulatory aspect. And we have seen with the ICON 8B that weekly paclitaxel plus Bev will be used perhaps more and more in the first-line setting. The Keynote B96 is the first clinical trial reporting an overall survival benefit with immune checkpoint inhibitor in ovarian cancer and a breakthrough for PD-L1 CPS positive patient. Pembrolizumab should be considered if patients are candidates to receive weekly paclitaxel and Bev. Together with advances such as mirvetuximab and relacorilant, this study expands the treatment choice for women with relapsed ovarian cancer, a group with historically poor prognostic. And for me, the future priority include biomarker-driven patient selection, optimal sequencing, ensuring equitable access to testing and innovation for all women, not only in my country or in rich country, but also we have to remember that also we have all these new options. 50% of our platinum-resistant ovarian cancer continue to progress at 6 months after the initiation of the treatment, and the median overall survival remain low. That means that we need to continue to explore new options. EDC is one of them, but there is also other like CDK2, WEE1, bispecific antibody who are coming and remain an urgent need for us. Thank you so much for your attention.
Thank you, Isabelle. Please don't shut down your slides. I really like that last slide. If you can put it
sorry.
back up, I think it makes a really nice point for discussions. If you can bring that up, thank you. Thank you, Rob, for coming back online. So question number one, and I think for me this was, a very important question that was looked at this year, because I think that the gynae world has lagged behind the breast cancer world, where we'd already proved that weekly paclitaxel, we had a big study it was a New England paper that showed that weekly paclitaxel was better than 3 weekly paclitaxel. And we now have several pieces of data here in ovarian cancer that's telling us weekly paclitaxel is better than 3 weekly paclitaxel. I can tell you in my practice, I've been using weekly paclitaxel for a long period of time. Do you think, Isabelle, this should now be the standard of care for everyone with ovarian cancer, platinum sensitive, platinum resistant, it does not matter?
This is an important point, because you have to remember that in breast cancer, the paclitaxel was used alone. In ovarian cancer, in the first line, weekly paclitaxel can count on the best friend, which is carboplatin. And we can't exclude what we have seen in several clinical trials, including a huge number of Caucasian patients, no benefit to use weekly paclitaxel plus carboplatin versus every 3 weeks. Now, what the ICON 8B revealed for me, if again we have to be careful because there is some limitation in this clinical trial, there is a well balance between BRCA mutated and non-BRCA, which is a big topic, that the combination of weekly paclitaxel plus Bev remain our best option, which Aurélie report to us several years ago. Also, it's a post-hoc analysis, we can debate on that. But now, do we have to treat 100% of our patients in the first-line setting with weekly paclitaxel plus carboplatin plus Bev? To be honest, I don't know, because we have to remember that every week is something very complex for our patient, and possibly there is some patients who don't need to move in this way. And I hope that the subgroup analysis coming from ICON 8B will be very helpful for us to decipher this role.
So, Rob, what are your thoughts here? Because as you know, I treat a lot of breast cancer as well. Weekly paclitaxel is actually a lot easier than 3 weekly paclitaxel, and we do now give it with carboplatin in the triple negative breast cancer setting. So again, that combination does exist. What are your
Yeah,
thoughts from a North American perspective?
I think it's very much the same. I think we've kind of gone a little schizophrenic on weekly paclitaxel in the frontline setting. We kind of discounted it, then we brought it back with the Japanese trial, then we discounted it again with 262, then we brought it back with Icon 8B. I think it's a very good drug. Just like you, I have been a weekly paclitaxel disciple for many years, particularly when we studied it as a potential anti-angiogenesis drug. So it goes back even further back in the development history. But you have to admit that there are difficulties in the weekly schedule. There's a number of different ways that the medicine can be given with a week break or not a week break, and some of these trials allowed that, some of them didn't. I think it's a very good partner with bevacizumab because of the anti-angiogenesis component to it. So it has always been one of my favorites to use. The interaction between weekly paclitaxel and bevacizumab, is still something that we've never really kind of formally tested as an isolated primary endpoint. It's still being used here in the recurrent setting as an option. And so even in the subgroup analysis for Aurelia, again, it was a small cohort of patients of 130 patients total. So but I still think in my personal belief is that if a patient is a good candidate for weekly pack, and I think this is the differentiator of all the trials that we've done, ADCs, non-ADCs, Bev use, Pembro, all those things. The major differentiator is whether or not the patient's a good candidate for weekly paclitaxel. Then you can make your next step, which is whether or not you believe it's an IO signal, if it's a relacorilant signal, or do you think it's bevacizumab signal? That's going to be your next step. But you first have to be convinced that week pack is the right choice at that time.
So we have now 3 studies that have focused on platinum-resistant ovarian cancer. You've got the B96, you've got the Rosalie study, you've got, and of course, the Marisol study. So Isabelle, do you think B96 actually should tell us that we should be testing all our patients in the platinum-resistant setting? We should be testing for PD-L1.
It's a very good question. I agree with you that also MSD informed about the press release about the fact that there is a positive result in overall survival for the ITT population. I will do something that Rob in general love is the calculation of the other ratio. The other ratio for the CPS positive is 0.76. For the ITT population is 0.82. So that means that in the CPS negative population, probably the other ratio is 0.9. That means that there is a group of patients where probably there is no benefit. First point. Second point, in the CPS positive, we can't avoid the overall survival benefit we have seen. However, as I mentioned in my discussion during ESMO, I will insist on the fact that the population included in B96 is not exactly the population I have, at least in Europe. Only 46% of patients who received BEV before is not the population in my country. Only 31% of patients who received PARP before is not my country. 70% of the patient candidate to receive BEV in the relapse setting, honestly, with the small bowel perforation, the risk of subocclusion, it's a very particular population. However, if today a patient is candidate to receive weekly paclitaxel plus BEV, I will ask for the CPS expression, and if the CPS is positive, I would like to be able to give pembrolizumab to this patient.
So, Rob, looking at the population of patients that was actually enrolled in B96, as Isabelle
Mhm.
said, a very, very specific population, which we don't actually tend to see nowadays.
Mhm.
In a population where they're receiving everything appropriately, would we have seen this overall survival benefit in that PDL1 positive cohort?
Well, I mean, I'll debate whether or not there's an overall survival benefit in the PDL1 positive
Yeah,
because
please tell me
yeah.
why do you are you skeptical?
Well, I do think that there, with as it relates to ovarian cancer, I do think that there is a subpopulation that I don't think PDL1 necessarily is the appropriate biomarker for. I think that there are probably other biomarkers that we're missing, such as MSI, that could potentially be driving this treatment effect. The PDL1 kind of analyses, as it relates to B96 was broken down into three subcategories. So there was the greater than 10, 1 to 10, and less than 1. All right. So when we say, well, the greater than 10, we're making a judgment on the basis of less than 10, we're also including in those patients that are less than 1. So I think that we have to be very careful in the subgroup. Now, I always say this, right? It's hypothesis generating, and we can definitely overstate the effect. I don't, but I've never been a strong believer that PDL1 is actually a predictive biomarker for IO in ovarian cancer with everything else considered. I do think, though, that the opportunity, if weekly paclitaxel is given in the recurrent setting, I think we wouldn't have seen this. If bevacizumab was given in the recurrent setting, I think we might have seen this because I don't really feel like that prior bevacizumab actually negates the efficacy of subsequent bev, and we have some data at least to support that, and not only in ovarian cancer but in multiple different tumor types now. So I don't know. I think there is something here, but it's like I said in my other talk, it's very hard to tell exactly what it is that's driving it. And I do get very concerned about making treatment decisions on the basis of subgroups that aren't analytical, because had we made the same kind of decision when we looked in GOG 262 about the role of Bev and weekly paclitaxel, we would have gotten it completely wrong. In fact, we would have gotten just the opposite wrong. Because in 262, we assumed that the no Bev arm was the only arm that benefited for weekly paclitaxel. But then we did 8B, which was a formal phase 3 trial that addressed that question directly, and everybody got Bev, and there we saw a difference.
So
So, so I don't know. I just be, you know how I am. I'm very, I
yes.
try to stay true to the rules, but I do think that, in the real world, we need guidance as to how to treat patients. And I think that these bring up some inferences that need to be tested. And hopefully with more time, we'll be able to be clear about that. But just my last point on this is that, when we look at the subgroups, and you can put that table back up for the baseline characteristics, we look at the greater than 10 group as one cohort of about 201 patients. But if you look at the rest of the group, there's 60% of the patients got 2 lines of therapy. So what proportion of the patients who had a CPS greater than 10 actually got 2 lines of therapy and had a platinum-free interval that was less than 3 months, which is 42% of the patients? You know what I mean? So I mean,
Of
when you
course,
start
of
when you
course.
start trying to figure out who these people are, you have to think about the other characteristics that people carry when they come to your treatment decision.
So, Isabel, you made a very nice statement here on your conclusions slide that as clinicians, we have to remember 50% of our platinum-resistant ovarian cancer patients will progress 6 months after initiation of therapy, and they're just doing not very well, these patients. So my question is, if you have a patient in the platinum-resistant setting who has FOLRI positive disease as well as a PDL1 positive disease, what are you going to use first and how are you going to sequence it?
I love it. I'm
Um,
glad you asked her.
I'm coming to
okay.
Europe.
No, you're right, because it will be the question perhaps in US soon, in Europe several months after you. But honestly, in ovarian cancer, in cancer in general, because I manage also other tumor, we feel some comfortable with the rotation of the drug. That means that we have seen in the past using platinum-based chemotherapy after several lines of treatment without platinum, good response. And we have the same for the use of weekly paclitaxel in the first line versus in the relapse setting, the PLD and so on. So for me today, the answer is quite easy. For a patient who already received 2 lines of platinum-based chemotherapy, or only 1 line with platinum and weekly and paclitaxel, not only weekly, but paclitaxel and Bev, as it is my standard in my country, I will move, if the patient is FR alpha high, to mirvetuximab first. And when the patient will progress, at that time, if it is a first relapse, I will have time to deliver again weekly paclitaxel Bev and pembrolizumab.
So
Yeah, I think I think that's a really great answer. I think that's what I'm seeing actually around the world. And I would say that, maybe I could ask Isabelle a question. If you had two ADCs that one was driven by a biomarker and the other one didn't have a biomarker assigned to it, if you tested the tumor and you found that, let's say for instance it was FR alpha high, but you had an opportunity for another ADC, anyone that didn't require a biomarker, would you use the biomarker directed one or would you use the ITT one?
I'm a medical oncologist, and so I believe in the biomarker.
Yeah, okay, there you go. See, we're more alike than different.
No, we are always trying to identify biomarker to better select our patients. So
I got you.
The question for me will be always to look at this. We unfortunately have no data considering the EDC topo 1 right now. Considering the response rate is quite good, but we don't have the information for the duration of response and the PFS. So it's quite complex to consider something with a huge hope versus something that we know exactly the activity.
Yeah.
My idea for an FR alpha high patient will be to use both.
Yeah.
The question about the order will be probably but if the patient just finalize the weekly paclitaxel or the taxane, I will perhaps make a priority for the topo 1 and move to the MIRV, the second line. At the opposite, if the patient is coming from PLD, which is a topo 2, I will be perhaps in favor to use MIRV first and then the EDC with a topo 1. But it's just what I'm thinking, and perhaps I'm completely wrong. We need to develop the clinical trial to make the demonstration.
No, but you're bringing up important point. I'm sorry, Shaheenah. To me, this is I'm glad you brought it up because I think lots of people don't remember the PLD topotecan days, but those were the days where we were asking this exact same question of a topo 2 versus a topo 1. In fact, there are some trials that were looking at topo 2 plus topo 1 as a combination. So it's actually a very important point. And I think as time goes on, we'll be able to sort out the sequencing.
Absolutely. But now you've got also the results of the Rosella study.
Yep.
Say, suppose it was all approved, hypothetically free of charge for you. You've now got the problem that you've got 3 trials, platinum resistant. You've got pembrolizumab, you've got the Rosella study, and you've got the Marisol. How would you sequence? And why?
You want me to start?
Yes.
Oh, okay, yeah. I think that if the patient is a good candidate for weekly paclitaxel, that's kind of like, as I said, that's my first choice. Then it's really about Bev, Pembro, or relacorilant. I think that the nuance will be around kind of for me, the first step will be whether or not the patient's a good candidate for the combination with bevacizumab, because then that puts us down to fewer lines of therapy. And that would, if the patient comes in there and they fit the Bev label, then my next question is, are they a candidate for an IO or not? So that's how I kind of would triage that. And I think relacorilant is a good drug that could be used in a broader array of patients. It's not tagged to the bevacizumab label, but I am a believer in bevacizumab. So I think once we see data emerge from the triplet, from the 3-drug combination of relacorilant, Bev, and nab-paclitaxel, I mean, that's kind of where I'll go. But, having said that, this is a 15-year-old question. We did these trials 15 years ago, including the combination with bevacizumab. So I think what we're gonna kind of revisit is what the safety profile looks for the triplet among the three triplets.
So, Isabelle, I'm going to throw in TDXD in the mix. And you now have data from pan-tumor that tells you that you can use TDXD in those patients with HER2 positive 3+, although the NCCN guidelines do allow you to expand it to patients who are even 2+. So suppose you have a platinum-resistant ovarian cancer patient. Rare for this to happen, but what if they're FOLR positive and HER2 positive? How would you sequence this patient in terms of therapy?
Very good question. Very quick answer. I did not mention that in my talk because the pan tumor is 2024 and not 2025. And unfortunately, TDXD is not available in Europe right now for this population. So we have ongoing clinical trial to use TDXD as a maintenance treatment in the first line setting. The trial is ongoing and we are recruiting for that. So in the future, I'm pretty sure that the use of TDXD will be in the first line setting and not in the relapse setting. So I don't know how to answer to that, but I'm not sure that we will have the opportunity to answer to your question, at least in Europe.
So I wanted to quickly go through two cases. I have 5 minutes and I want to go through two interesting cases, both ovarian cancer. This is a young lady in her 40s who was diagnosed with a stage 4 high-grade serous adenocarcinoma. I mean, I still remember she presented with neck nodes and everyone thought she had thyroid cancer when we put a needle in. It was high-grade serous. She got her chemo, did very well. We sent her tissue for profiling. HRD is positive, so she was maintained on PARP plus bevacizumab, and you can see that her PD-L1 CPS is 5. FOLR was negative. She had a TP53 pathogenic mutation. HER2 is 2+ at 5% of the tumor. And then when she recurred, I biopsied her and I sent the tumor for profiling again. Still high-grade serous. HRD is negative. Her PD-L1 is now a CPS score of 50 with still a TP53 pathogenic mutation. Rob, what would you do for this lady at this point in time?
So she has, I mean, what was her platinum interval?
A year.
Oh,
But then, having said that, she finished her 6 cycles of Taxol, Carbo, Bev, and then maintained on PARP, and she recurred while she was on the PARP.
Yeah, I mean it's a good question, and ultimately, we do have a trial right now or we have a couple trials that are being developed right now to look at whether or not we can replace paclitaxel carboplatin. I think the error in the messaging that's happened is that pac carbo doesn't work in patients who've had previous progression on PARP. It's not that it doesn't work; it's just that it doesn't perform at the same expectation. We don't know if it's better than non-platinum, and so I think you still have to follow your best thoughts here. And I would probably give her pac carbo bev.
Isabelle, what would you do here? Was it strange for you that her CPS actually increased on recurrence? She has a PD-L1 score of now 50.
No, we have seen that before. Depend also, the heterogeneity of the tumor is really complex, and we have published recently that looking to the primary tumor versus the metastase, we see a huge difference considering CPS expression.
So, Rob, this is another patient who I've been treating for 8 years with ovarian cancer. And
Good for
she
you.
was in high-grade serous, treated with chemo, then surgery, then more chemo, and she did well for a year. And then for the last 6 years, every year her disease progresses, and every year I re-challenge her with a platinum, and every year she does very well now with that re-challenging of the platinum. And I've been giving her Bev all this time as well. She's done very well, but now she's truly become platinum resistant.
Okay.
And I sent off her tissue. HER2 is 2+.
Yep.
FOLR is classified as negative,
Yep.
but it's 2 plus 60%.
Right.
What would you
I
do
think you
for
got
this
two
patient?
choices. Yeah, so I think TDXD, has efficacy, has objective response and duration response in 2+. That would certainly be a choice. And for the 50% or 60%, you can give her the combination of Bev plus Nerve.
Bet you so you would do that. You would actually give that. And that's what I thought for her. But which one would you start off with in terms of sequencing?
It depends. Does she have any problems with her Bev that she's had before or anything like that?
No, no, no. She's actually done very well.
I don't know. I might switch to TDXD to start.
Okay. Isabel, what are your thoughts over here?
I will probably retest the FR alpha because we have several cases where there is 60%, and when we retest in my center, we see 100% or 55%, 75%. So remember that. But I agree with Rob. I will follow Rob as usual.
So thank you both. You've both been awesome. I see that you're, tagging each other and not and being very diplomatic with each other. So thank you. I've absolutely enjoyed myself. I think Rob, you gave us an amazing overview of the platinum sensitive setting, and
Mm.
Isabel, amazing overview of the resistance setting. I know I've learned a lot. I hope everyone else has enjoyed today's conversation. I wish I could ask more questions. I have so many more questions to ask. But it will be in the next edition of the EIOC. Rob has to go back to his turkey, and Isabel has to go back to work.
Thank you very much.
Love you guys. Thank
Thank
you.
you
It's good
so
seeing
much.
you.
Bye-bye.
Thank
Good seeing
you.
you.
Take
Bye-bye.
Happy,
care.
Bye-bye.
happy
Bye.
Thanksgiving.
Thank
Thank
you.
you.
Bye. Bye. Bye.